Good morning, everyone. And today we are having a very wonderful weather in Delhi. So, hope you have enjoyed. And now we are enjoying the very good academic feast. And I will congratulate all the organizing committee for this. So, we will be discussing maxillary and mandibular blocks for trigeminal neuralgia. Though both these divisions can be taken care at the gastrointestinal ganglion, but there are other approaches also where we don't want to enter the gastrointestinal ganglion, but we tackle these little bit lower and with other approaches. So as you can see here that our face is very richly supplied by the various nerves, and most of the sensory supply is by the fifth nerve, but rest also contribute like 7th, 9th and 10th nerve. And as you come to know that the fifth nerve has V1, V2 and V3. So extraoral route we don't ablate V1, but V2 and V3 we want to ablate. So first I am going to discuss maxillary. So anatomy is very important for whenever we are discussing about trigeminal nerve and its branches. And one thing I want to tell you that whenever you are doing any manipulation with any of the trigeminal nerve, the monitoring is most important thing, because the TCR may be a complication and it may be disastrous for the patient. So as you can see here, so this is trigeminal ganglion, this mandibular nerve coming out of foramen ovale, this maxillary foramen rotundum, and this is ophthalmic for the superior orbital fissure. The maxillary nerve is a pure sensory nerve that begins at the gastrointestinal ganglion and travels anteriorly and inferiorly along the cavernous sinus through the foramen rotundum. So this is foramen ovale and the blue one is foramen rotundum. So again, this is really important because in trigeminal, if you don't know the anatomy, it may be difficult. So this is the trigeminal ganglion. Then it's the maxillary nerve comes through the foramen rotundum, then in the pterygopalatine fossa, where it gives most of its branches, like pterygopalatine nerve, which supplies the nose and palate. Then the zygomatic nerve, which further divides into zygomatic facial and zygomatic temporal. Then it gives the posterior superior alveolar nerve, and the infraorbital nerve, which travels through the inferior orbital fissure and comes out infraorbital foramen and gives further branches. So we mostly try to ablate this in the pterygopalatine fossa, and territories, as you can see here, the lower eyelid, the ala of the nose, the cheek, the upper lip, the cutaneous zygomatic and temporal area, and it supplies superior teeth, the palatine bone and maxillary bone and maxillary sinus. So what are the various indications for the diagnostic and therapeutic management of trigeminal neuralgia? As a adjunct to GA for the major cancer surgery to maxilla, ethmoid sinus, maxillary and infratemporal fossa. In children, you can have wonderful postoperative analgesia if you give bilateral maxillary block for the repair of congenital cleft lip and palate. And in maxillary trauma and maxillary osteotomy, the block may be used. So along with the long needles and syringes, if you are doing pulse radiofrequency, then the 5 mm active tip is desirable, and local anesthetic and neurolytics can be used. Neurolytic we mostly use 6% phenol and 40 to 50% glycerol or absolute alcohol. So first I am describing first infrazygomatic. There are two approaches for the maxillary: infrazygomatic approach and suprazygomatic approach. So first, what you need to do, you need to identify mandibular notch, and you can ask the patient to repeatedly open or close his mouth and keep your finger in the just at the mid-zygomatic bone. And when the patient will clench his teeth, you will feel the notch there. This is between the convoluted and cornuate process. Then the needle is placed just perpendicular to the skin as a posterior inferior aspect to the notch, and needle is advanced till you touch the lateral pterygoid plate, which will be at the 4 to 5 centimeter. Mostly this comes at the 4 centimeter. Then the needle is directed anteriorly and superiorly towards the root of the nose and advanced in the pterygopalatine fossa until a paresthesia is obtained. And it is always important to obtain paresthesia because it increases your rate of success. So if you are just blocking it, up to 5 ml of local anesthesia injected, but if you are using neurolytics, then just 1 to 1.5 ml is enough. And for the, if we are using the pulse radio frequency here, the sensitive stimulation of the 50 hertz, 0.2 to 0.5 volts, and motor stimulation the 2 hertz, 0.6 to 1.2 volt. Somebody may ask that this is the pure sensory, then why? What is the role of motor? If there is motor stimulation on the maxillary, then you may guide the little bit just forward. And the pulse radio efficacy is done at 42 degrees Celsius for 2 to 3 minutes. The same procedure can be done under fluoroscopic guidance. Here you first go in the lateral view and reach the superior 1/3 of the pterygopalatine fossa. And in the epi view, we confirm the depth. The needle tip should not cross the lateral wall of the nose. There are complications of this technique that you may puncture the maxillary artery, the posterior pharyngeal wall, the submucosal abscess may be there. If you go through the superior orbital fissure, there may be orbital injury, which may range from ophthalmoplegia to the complete blindness, and you may enter the subarachnoid injection may be done if you are too deep. The other technique is suprazygomatic. This is again landmark based technique. So our entry point is just above the suprazygomatic arch and the posterior wall of orbit. The needle is inserted perpendicular. Then it is advanced to reach the greater wing of sphenoid, which will touch 1.5 to 2 centimeters. Simply in the temple area you advance and the sphenoid bone will come. Then you withdraw the needle and go in the posterior and caudal direction, as you can see here, and advance till you reach that pterygopalatine fossa, and you negative aspirate for blood and find paresthesia, and then you need to inject the drug.
Thank you, Dr. Raji. And
the same procedure can be done USC guided also. Here the landmark is anterior is maxilla and posterior is sphenosinus, and this is pterygopalatine fossa. In the base of this pterygopalatine fossa, you see the maxillary vessels lies, and maxillary vessels lies ventral and inferior to the maxillary nerve, and the needle is advanced using an out of plane approach. So the needle is so this is the position of the probe. This is placed in the infrazygomatic area, and the real-time ultrasound guidance allows direct visualization of the internal maxillary artery, identification of the needle tip, as you can see here is going, and the spread of local anesthetic solution within the pterygopalatine fossa. Then the terminal branch of the maxillary nerve is infraorbital, and which comes out of the infraorbital foramen, and it's also it again is divided into 3 nerves: the inferior palatable, the lateral nasal, and superior labial nerves. So it supplies the skin and mucous membrane of the lower eyelid, the cheek between them, and the lateral side of nose. And this can be simply blocked at the infraorbital foramen, which lies in the midline of the pupil and just 1 centimeter below the orbital ring. So next is mandibular nerve block. This is the third largest nerve of the trigeminal, and this is only mixed division. The rest two are only sensory, ophthalmic and maxillary, but this is motor as well. The motor root arises directly from the pons. It doesn't come from the ghesian ganglion, but it carries with the mandibular nerve, and both divide just after the foramen oval, just coming out of the foramen oval. So the ghesian ganglion, so this was foramen rotunum, this is foramen oval. It goes like this. Then it gives its motor branches to both the pterygoids, medial and lateral pterygoid, then masseter and deep temporal, and then the sensory are the buccal nerves, temporal and buccinator, and other important the auriculotemporal, the lingual and
just 30 seconds.
Inferior alveolar nerve, which acts as a mental nerve, literally. So this mandibular nerve supplies the ipsilateral mandibular bone, the lower teeth up to the midline, the buccal and lingual hard and soft palate, anterior to tongue of the anterior 2/3 of the tongue, the floor of the mouth, external acoustic meatus and auricle of ear in its anterior zone, the skin over the jaw, the temporal area except the area of the angle of the mandible. This is not supplied by the mandibular nerve, which is supplied by the superior cervical plexus.
Okay.
So indication as the non-malignant chronic conditions like trigeminal neuralgia, the vascular neuralgia, the post-herpetic neuralgia, patients with cancer or trauma, and surgery on the lower lip or anterior two-third of the tongue. So preparation is same, and the monitoring is must for any trigeminal block. So pulse radio frequency can also be used, and position is supine. And if you are using C-arm, the patient to be placed in supine position, and we first use in lateral, then AP view. So surface landmark is same here like the maxillary. We are again using the mandibular notch here, but what we do, we just enter the skin perpendicular to the mandibular notch. Then we advance to the infratemporal fossa with the lateral terminal plate serving as a bony endpoint. And the depth is usually at the 3 to 4 centimeter, mostly 4 centimeter. And then for the maxillary, we advance it to superiorly and anteriorly, but here we advance it posteriorly and little bit inferiorly. And then we see the paresthesia, or we can see the mandibular elevation twitch. The minimal intensity of the stimulation may be around 0.2 to 0.5 milliampere. And then 5 ml of local anesthetic injected. If you are using neurolytic, again the 1 to 1.5 ml. And the neurostimulation is associated with high success rate. When we give motor twitch, there will be twitching of the mandible. The complications are again because this is mandibular now, and you may enter either in the mandibular artery or the maxillary artery. There may be injury to pharynx if you are going a little bit posteriorly. So intermaxillary and middle meningeal artery can be injured if you have inserted the needle too high in the mandibular notch. Injury to pharynx may be while walking posteriorly of the lateral terminal plate, because just posterior of the terminal plate, if you go more posteriorly, you may hit the superior constrictor muscle of the pharynx. And the large volume of local anesthetic solution, the nearby nerves like facial nerve paresthesia may be there. The other complications which are maybe sometimes really dreaded, the prolonged vertigo and ataxia after mandibular nerve block, maybe if you injure the auditory tube while going through the pharynx. Sometimes transient asystole, as Dr. Mohan was telling, that due to trigeminal cardiac reflex, patient may go in asystole and CPR may be needed. So these blocks are really very risky, and a good monitoring and anesthesia help should be there. And sometimes we have seen one case of mandibular displacement. When there is pain, there is serious spasm of same side of muscles, and to maintain the neutrality of the mandible, the other side of muscles also go in spasm. As soon as the pain was relieved for that person, the other side of muscles pulled the mandible out of the mandibular notch, and the mandible was deviated. So pain on the same side was relieved, but then there was pain on the other side. So this was later sent to the dental clinicians, and they fixed the jaw. And this is another this is a terminal branch of mandibular nerve, that's inferior alveolar nerve, which comes out of the mental foramen. This emerges at the mental foramen and divides into 3 branches, and this supplies the labial mucosa of the lower lip, gingiva, and the skin of the chin. And the same thing can be taken with the ultrasound guided also. So there is supraorbital foramen, infraorbital foramen, mental foramen. These all lies in the mid-pupil plane, and with the USC guidance, you can see that there is dip in the bone. So I think, and you can simply block this mental foramen here. So thank you.